Good morning, Brain Med. Oh, okay, you don't want to come in the panel?
请注意脚下安全。
Aloha, Sean.
Hi, John. How are you?
Good. Good.
Where is the king?
Hey, listen, do you want to moderate?
Yeah, I can moderate, no problem.
Well, listen, I'll introduce you and you introduce Ben, okay? I think if Ben's here, I'll see. If not, you just introduce the king, okay?
Yeah.
Okay, I'll let you know.
Yeah. What topic is talking today?
Yeah, revolution spine, Dr. Goel.
Okay. Yeah.
And he's, okay.
એનો તો ફોન આવ્યો કઈ બોલ્યા જ નહીં. શીતલબેન નો ફોન હતો કઈ બોલ્યા નહીં કઈ.
Okay, Yandong, you got in the panel. Greetings, everybody. We start in a few minutes. Okay, let me check with the king. Oh, here he is. Hey, good morning, Atul, the king is here.
John, my dear friend, John, how are you?
Good, how you been?
Very good, very good.
Yeah,
Just
well, today's Atul Goel Day in China.
yeah. Let us see. Let us see.
And then
Oh,
you have your series
Hello.
starting. Oh, you know Yandong, right?
yes, he's the king of
Hi, my dear professor. Thank you. Very nice to see you here.
Thank
Yeah.
you, my dear.
Yeah.
Everything okay? Where are you?
Yandong, what? Oh, I think you may have.
I
Are you there?
oh.
Go ahead. Yandong, where are you? Can you hear okay? It looks like looks like he's trying to find a spot.
Harshad is
I'm
there.
so sorry.
Oh,
Hi,
Ben's here.
Atul.
Okay, Ben's here. Great. Okay, you want to introduce Ben, right, Harshad? Okay, Harshad?
Harshad,
Yes,
you
we are
have
ready.
to,
Yeah, Ben's
you have
here.
to-
Hello, Ben.
Hello.
Welcome.
Thank you, John.
Hello, Bin. Hi, Bin.
Hello.
Yeah,
Hello,
Harshad is going to
Harshad.
introduce you
Professor
today.
Goel.
yeah, Zubin, how are you?
Hi. Fine.
Nice to see you.
Nice to see you.
Yeah, Tool's starting a series in a couple hours. Also, he's busy.
Here's Mohammed.
You had conferences all day, didn't you, Atul? Didn't you have it somewhere else?
I'm just jumping here and there, John, with you
Yeah.
now.
Well, that's good. That's good. We're glad you're here. And it's being televised in Meitian in China, the best video neurosurgery site on the planet. There's Abby. Okay, let me see. Abby's here. Okay, you ready to start, Atul? You ready, Ben?
Yeah.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting from the studio of Neurosurgical TV. We have the honor of continuing the bi-monthly series of the China Neurosurgical Journal webcast twice a month. And today we're on with the king, and the king is here. This gentleman goes all over the world teaching, South America, Africa, Europe. He goes everywhere, including India. And I'm going to have Harshad Parekh introduce him. Good day, Harshad.
Good day. Good morning to you and good evening to everybody. It's my pleasure to welcome all of you for such a wonderful, enlightening webinar.
Excuse me,
talk
Harshad,
on
I screwed up. You introduced Ben. I'm sorry.
Yes,
Okay, I'm sorry.
it's my pleasure to introduce Professor Zhu Bin, who is from China and who is the master of vascular surgery, especially in a bypass surgery. And I believe he's got a world record of doing bypass surgery. Today he's with us, and it's always pleasure to be listening to his comments. And he will be moderating, and he will be with Professor Atul Goel, who is going to talk. Yes, welcome, Zunbi.
Okay. Thank you, Harshad. So now let's invite tonight's first speaker, Professor Atul Goel, Atul Goel was a very world famous neurosurgeon, and he is my personal idol, and I respect him very much. And Professor Atul Goel, his topic is the treatment of cherry malformation. Professor Goel, the time is yours.
Unmute,
Tonight,
Atul.
we already have more than 700 audience are watching this.
Excellent. Okay, unmute, Atul, unmute. Please.
Okay. So thank you, my dear Zubin. And it is my great pleasure and big honor to be on this show. And I know that this is being very widely telecast. And I'm going to discuss one of the most important clinical issue of Chiari malformation. Chiari is a very common disease. It is a chronic disease. The symptoms are relentlessly progressive. They start with some tingling in the fingers, weakness in the hands, then weakness, spasticity in the legs, then it goes on to voice disturbance, then it goes on to sleep apneas, then it goes on to breathing disturbance, and it is a slow, merciless killer. This disease is a killing disease. The issue is, I want to discuss absolutely magical treatment for Chiari malformation.
Excuse me, Atul. Excuse me,
Yeah.
Atul, could you put it on presentation mode? We're just seeing the first slide. And it's not full screen. On
It is not?
presentation mode, yeah, put it on
It is not?
presentation mode.
Wait, it is
Yeah,
not full.
we can see it, but it's not large screen like it
Now,
should be.
now,
Not yet, not yet. Keep trying.
I don't know. Here I am getting.
It's down in the bottom there where you're at. In the bottom left, I believe.
Maybe let me do it again.
Yeah, okay. Yeah, it's not showing the full screen, just a small slide. Okay, perfect, perfect.
Okay. So I am going to discuss about this topic of Chiari, which I believe is absolutely important for the person who has this problem. And if you have realized, I have labeled it as Chiari formation and not malformation. I think and I completely believe that Chiari is not mal, it is not bad, it is a formation. It is secondary, it is not primary. It is secondary to chronic atlantoaxial instability. Understanding the fact that it is not a primary embryogenic malformation and that it is secondary to atlantoaxial instability has absolute clinical relevance that it can change the game of treatment. So I want to introduce my concepts again. I have talked on various occasions about this subject. And I want to come back again on this because it is so important. Atlantoaxial fixation is absolutely important surgery. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial instability is the most common form of spinal instability. Atlantoaxial instability is neglected. It is not properly understood, and it is absolutely under-treated clinical entity. So that is the basis of my presentation. Basilar invagination, syringomyelia, Chiari malformation, they are all considered to be discrete clinical entities. My absolute understanding is that these malformations or abnormalities are not abnormalities, they are alterations or natural protective adaptations in the presence of chronic atlantoaxial instability. So basilar invagination is due to instability, syringomyelia is due to instability, Chiari malformation is due to instability. So this is the tonsillar herniation. Very frequently it is associated with syringomyelia. So this is tonsillar herniation and syringomyelia. This is tonsillar herniation. There is no bone abnormality here. There is no basilar invagination. There is little bit syringomyelia. There is basilar invagination. There is syringobulbia. You see, there is syrinx in the medulla. There is syringomyelia. There is Chiari malformation or formation. There is atlantoaxial instability. This is basilar invagination, Chiari malformation, syringomyelia. There is doubtful atlantoaxial instability, doubtful alteration of atlantodental interval. There is no real compression of the brainstem. This is another case of severe basilar invagination, Chiari malformation, and syringomyelia. There is atlantodental interval is increased here. There is compression of the neural structures. There is Chiari malformation. There is no atlantodental interval disturbance, no basilar invagination, Chiari malformation, and syringomyelia. My question is, when there is syringomyelia and Chiari, is it different problem? When there is basilar invagination and Chiari, is it different problem? When there is only Chiari, is it different problem? So that answer I want to give. If you read the literature of last 50 years, the only treatment for Chiari and for syringomyelia is decompression. Some people do suboccipital decompression, some people do C1 removal, some people do C2 removal, some people remove the tonsil, some people give dural graft, some people put metal implant, some people open the orbex, some people introduce syrinx cavities, shunt tube. So there are hundreds of treatments described for Chiari malformation with or without syringomyelia. About 15 years ago, I wrote this article, Is atlantoaxial instability the cause of Chiari malformation? And is atlantoaxial fixation the treatment? So my dear friends, I have absolutely no doubt, and it is absolutely clear that atlantoaxial instability is the cause of Chiari malformation, is the cause of syringomyelia, is the cause of basilar invagination, and a number of other problems which I will discuss. Atlantoaxial fixation is the treatment. More recently, I published my work with 388 cases of Chiari. Only treatment was atlantoaxial fixation, no decompression. Whether there is any other association like Klippel file abnormality, C2-3 fusion, assimilation of atlas, platybasia, syringomyelia, any other association, Chiari, the treatment is atlantoaxial fixation. Of course, there can be tumor and Chiari. Of course, there can be spina bifida and Chiari. That is a different anomaly. I'm not talking of that kind of anomaly. There can be cranial abnormalities or synostosis and all those things and Chiari. That is a completely different anomaly. So Chiari is secondary to atlantoaxial instability, and Chiari should be called not malformation but formation. Craniovertebral junction is a highly complex issue. Craniovertebral junction treatment is not easy. Craniovertebral junction treatment is dangerous. You can damage the person, you can kill the person, or you can make big neurological deficit. On the other hand, if you treat them properly, such deformities with hand problems, with leg problems, you can make these people absolutely happy and make these people look like kings. Their neck will improve, their neck will become long, their hands will improve. So craniovertebral junction stabilization in these benign problems has absolute relevance and clinical implications in the life of these patients. So there is no question that we have to learn the art of C1, C2 stabilization, and there should be no confusion in this. If you have confusion, you should not do C1, C2 fixation. You should do C1, C2 fixation after appropriate learning the philosophy, the various concepts, the various techniques, the various anatomical issues, and then do C1, C2 fixation. So these are the two magical bones, C1 and C2. Atlantoaxial joint is the most mobile joint. Without any question, this is flat and round. And this can be unstable in all the directions. It can be unstable in front, it can be unstable laterally, it can be unstable posteriorly. Instability of the atlantoaxial joint is a big subject, and one has to learn this subject before one can do any kind of treatment. So I am in this subject for several years. Many of you know about my work on C1, C2 fixation. I did this technique in 1987. One screw in C1, one screw in C2, open the joint, remove the cartilage, put bone graft in the joint, put bone graft behind in this area. This technique is an absolutely solid technique. It is a very robust technique, and one has to, but it is not easy. One has to learn, one has to do, and one has to see. So opening of the joint is one issue. Learn how to open the joint. Learn how to remove the articular cartilage. Put bone graft in the joint. These are very, very important issues, and you cannot neglect even one of these issues. Very early in my career, I used to do occipito-cervical fixation. And we described occipital screws to do occipital fixation for the first time in 1987. But now I say for all craniovertebral junction instability, there is no need for occipital fixation. Atlantoaxial joint is the problem. Atlantoaxial joint is unstable, and atlantoaxial stabilization is the treatment. Inclusion of the occipital bone is not a good option or not a good treatment for craniovertebral junction instability. Craniovertebral instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. So this was my first case in 1988. You see one screw. That time we used to do radio-ulnar plates. We used to cut them and introduce here. And you see C1, C2 stabilization. And then we have done several hundred, now more than 3,700 cases we have done with such fixation. And we have done in children, we have done in adults, I have done in 3-month-old child, I have done in 86-year-old man. Any age, if there is unstable atlantoaxial instability, they have remarkable clinical issues, and stabilization, arthrodesis, gives a new life to these patients. Needless to say that we have to learn the anatomy of this area. There can be huge venous plexuses in this area. This artery can be quite tortuous. There can be high vertebral artery. There can be vertebral artery anomalies. So you have to learn the anomalies and do the case properly, because any kind of mishap during surgery can be devastation. C2 ganglion is right in front of the joint, so you can mobilize the joint C2 ganglion up or down, but now I don't recommend sectioning of the C2 ganglion. So over my journey, we made various alterations in the conventional treatment. For the first time in the literature, we introduced the concept that there is nothing like fixed atlantoaxial instability. There was, if many of you who are senior in the audience will know, that there was a concept of fixed atlantoaxial instability. And when it is fixed, you do decompression. So for the first time, we introduced the concept that there is nothing called fixed dislocation. Open the joint, manipulate the facet, and you can reduce the dislocation. Here, like there is a fixed dislocation, this kind of patient was treated by transoral decompression. Transoral surgery was very common during those days. But open the joint, manipulate the facet, and reduce the dislocation. So there is no need for decompression. It is an unstable situation. It is not a fixed situation. Decompression is not the treatment. Instability and decompression do not go together. If you do decompression in an unstable spine, you can only harm the person. Stabilization is the treatment. So over the next 30 years, we have done several hundred patients where there is fixed dislocation. Open the joint, reduce the dislocation, and stabilize. The other issue is whether if it is not completely reduced, is it okay or not okay? My answer is very clear. Instability is the issue and stabilization is the treatment. Although realignment is good, but it is not mandatory. Instability is the problem and stabilization is the treatment. So these are very complex issues, but if you can realize that if you treat them properly, you give absolutely new life. In traumatic cases, sometimes the facets are here and C1 is outside, C2 is here. Open the joint, manipulate the facet, and do realignment. So this term we introduce realignment. Rotatory dislocation, the whole world was treating by decompression. So we introduced the concept. Open the joint, manipulate the facet, and realign the joints. And you can give beautiful smile to this patient, new life to this patient. So this concept we evolved during our journey on craniovertebral junction. As regards basilar invagination, the whole world was thinking that basilar invagination is a fixed anomaly. Decompression is the treatment. For group A, transoral decompression. For group B, foramen magnum decompression was the treatment. And in 1998, I also recommended that you should do decompression by transoral in this case and foramen magnum in this case. So this was my personal concept in 1998 that this is a fixed issue. When to do fixation was not really described in our article. But one thing we described that in group B, in group A, odontoid goes up, in group B, the tonsil comes down, or there is chiari. For the first time, we said that in group B, in presence of basilar invagination, there is a tight posterior fossa. And you need to do only bone decompression. You don't need to open the dura. So this is what we said first time in the literature, that you don't need to open the dura. In 2004, we changed and we then divided into group A and group B. Group A, we said odontoid goes up. Group B, we said tonsil come down. For this group A, we said that you should do craniovertebral junction realignment. This is not fixed. This is unstable, and stabilization is the treatment. For group B, we were not very clear, and we said that foramen magnum decompression was the treatment, and we introduced for group A craniovertebral junction realignment as the treatment. So this is basilar invagination. This is open the joint, reduce the dislocation, and do craniovertebral junction realignment. And we have several patients in my journey now where we have not done any kind of decompression for these cases. So there was an era of decompression. Then came an era of decompression and fixation. And then came an era of only fixation. So my absolute issue is that basilar invagination is an unstable situation, and any kind of transoral decompression is not necessary. And it is now the whole world is not adopting decompression as the treatment. Stabilization is the treatment. Now, the other very critical and very important issue in craniovertebral junction instability or atlantoaxial instability is, one, it is acute. Like there is a trauma and there is an acute instability. One is chronic instability. For 10 years, for 15 years, for 20 years, there is unstable atlantoaxial joint. So when there is a chronic instability, there are several natural adaptations or protections which look like pathology, but they are protective natural maneuvering. Like short necks, this kind of short neck, torticollis, short neck torticollis. This is a protective maneuvering. Due to chronic atlantoaxial instability, you stabilize and the neck will become straight and neck will become long. So there is a reversal of these kind of torticollis. So when there is a short neck and torticollis, it means there is atlantoaxial instability. You stabilize and you see the magic. There is basilar invagination is due to atlantoaxial instability. It is a secondary protective natural basilar invagination. If there is an acute injury, there is a spasm of neck. And if there is a chronic spasm of neck, there is basilar invagination and torticollis. Cervical fusions are a response to chronic atlantoaxial instability. When there is chronic instability, there is cervical fusion. So when there is cervical fusion, even when there is no atlantoaxial region compression, it is an indicator of atlantoaxial instability, and it merits the need for atlantoaxial fixation. So chronic instability, there is a these are secondary. These are not embryological problems or dysgenesis. This is due to a protection. And this suggests atlantoaxial instability and the need for stabilization. Bifid C1, C2 is also secondary. It is not like lumbar bifid. It is secondary, it is protective, it is dynamic. So when you do flexion, the facets go outside. And when you do extension, the facets come in alignment. When this dynamicity is a protection, it increases the space when there is a flexion. And this is mandatory. If you don't have this kind of bifid, there can be cord compression. So there is bifid. So when you see bifid, whether you see compression, whether you see any other thing, it indicates unstable atlantoaxial joint. Bifid is protection, and bifid indicates atlantoaxial instability and stabilization. Os odontoideum. Not many people really understand os odontoideum. My concept is absolutely clear. Os odontoideum is not a primary problem. It is secondary to chronic atlantoaxial instability. It indicates atlantoaxial instability. When there is os odontoideum, you have to do stabilization. If you can do realignment, it is okay. But if instability is the issue, stabilization is the treatment. Similarly, syringomyelia is due to chronic atlantoaxial instability. It is not harmful, it is helpful, it is protective, and it is reversible. It indicates atlantoaxial instability. Any kind of shunt or any kind of diversion of fluid inside syrinx is a negative process. So we introduced about 10 years ago or 12 years ago a new concept of central or axial atlantoaxial instability. Chronic situation. It is not acute, it is chronic atlantoaxial instability. And when there is central instability, there can be Chiari, there can be syrinx, there can be platybasia, there can be short neck, there can be torticollis, there can be clipper file abnormality, there can be assimilation of atlas, there can be C2-3 fusion, and a number of other issues, including Chiari and syrinx. So, and also recently we have said that chronic central atlantoaxial instability can be in OPLL, in Hirayama disease, in degenerative spine as well. About in 1999, we introduced the concept that basilar invagination is listhesis of C1 over C2, like lumbosacral listhesis. Like you treat lumbosacral listhesis, you should treat C1, C2 listhesis for basilar invagination. So this is one case. There is basilar invagination, Chiari, syrinx. There is listhesis of C1 over C2. You treat the listhesis, you realign the craniovertebral junction. There is no need for foramen magnum decompression or decompression. This is another case of basilar invagination, syrinx and Chiari. There is listhesis is the problem. This concept we introduced in 1999. But now we introduce another concept of central instability. So this was my concept of 99, that there is listhesis of C1 over C2. There is atlantodental interval disturbance. There is cord compression. Listhesis is the problem and stabilization is the treatment. We introduced this concept that there can be retrolisthesis. C1 can go behind C2. There may not be any atlantodental interval disturbance. There may not be any compression. Chiari and syrinx and basilar invagination are secondary to chronic instability, and stabilization is the treatment. I have no confusion in this regard that if you do decompression in this situation, it is a negative operation. As we grew further, we understood that even when the facets are in alignment, type 3 instability, in the presence of Chiari, in the presence of syrinx, in the presence of assimilation of in the presence of platybasia, these are all evidences. These are all evidences of atlantoaxial instability. They are secondary, they are protective, and they are reversible following atlantoaxial stabilization. So you can see this basilar invagination, there is assimilation of atlas, there is retrolisthesis, there is type 2 instability. There is no question of decompression. It needs stabilization. There is huge basilar invagination, Chiari and syringomyelia. You see there's little bit retrolisthesis. There is no cord compression. This patient needs C1, C2 stabilization. This is a difficult operation. This is not easy, but this is the treatment. This is another case of very big basilar invagination and Chiari. You see there is quite a bit of retrolisthesis. There is no atlantodental interval disturbance, but it is unstable. It is not acute instability, it is chronic instability. If you can do C1, C2 fixation, magic is the clinical outcome. In the evening of operation, the patient will reverse, his speech will become better, his gait will become better, his pain in the hands, tingling in the hands, everything will improve dramatically. This is another case. There is no problem in the facets, no problem here, but presence of chiari by itself is an indicator of unstable atlantoaxial joint, and stabilization is the treatment. We introduced the concept that in basilar invagination, there is tight posterior fossa. I am saying there is no tight posterior cranial fossa. The foramen magnum is large, as you can see. The issue is unstable spine, and the treatment is stabilization. So basilar invagination, where the whole world was doing decompression, we said that instability is the issue and stabilization is the treatment. And we have published several articles on this subject. For both group A and group B, we have said that atlantoaxial stabilization is the treatment. So basilar invagination, syringomyelia, chiari malformation are all secondary. They are all protective. They are all reversible following atlantoaxial stabilization. Basilar invagination, instability is the issue. Stabilization is the treatment. So atlantoaxial instability, chronic atlantoaxial instability, one of the manifestations can be chiari. Chiari can be associated with syrinx or not associated, may be associated with basilar or not. Or basilar invagination may be associated with chiari, or syringomyelia can be discretely present, or there can be only C2-3 fusion and nothing else. There can be only assimilation of atlas and nothing else. So when all these anomalies are present discretely or in cohort, means also with basilar and syrinx, or chiari is also with Klippel file, or chiari is also with platybasia, whether they are present in isolation or in cohort, they indicate atlantoaxial instability. So I'll show you some cases. You see there is no atlantodental interval disturbance. There is type 2 atlantoaxial facetal instability, chiari and syrinx, no need for decompression. Atlantoaxial fixation is the treatment. It is not an easy procedure in the presence of syringomyelia. There can be a lot of venous bleeding in this area. You have to be very careful of the high riding vertebral artery. But if you can do it, you create a magic, and that magic is seen in the immediate postoperative period, and the patient will be relieved of all the symptoms dramatically. So chiari, no problem in the atlantodental interval, no problem in the facet. It is an unstable situation. Atlantoaxial fixation is the treatment. Basilar invagination, assimilation, partial assimilation of atlas, no real facetal malalignment. You do atlantoaxial fixation, the syrinx will reduce in 100% of cases, 100%. When you do a scan after about 1 year. If you do after 4 days of surgery, you will have reduction of syrinx at least 20% of patient. If you do a scan after 3 months, you will have reduction in syrinx in at least 50% of patients. The only issue is that you should do a very solid C1, C2 fixation. Open the joint, remove the cartilage, introduce bone graft, and then do solid C1, C2 fixation. No problem in the atlantodental interval. Some facetal malalignment. You see the massive syrinx, and this syrinx is reduced quite dramatically. The question is whether the syrinx reduces or not. That is not the question. The patient will dramatically recover. That is the issue. And that is what we aspire for, atlantoaxial fixation. I have to only tell you that in such basilar invagination, in such platybasia, to do C1, C2 fixation is not easy, but that is the treatment. So chiari is not a malformation, it is a formation. It is like nature's airbag. It comes between the head and the wheel, and it is a protective maneuver. We should call it formation and not malformation. So there are some more patients I want to show you. There is chiari and big syringomyelia. There is assimilation of atlas. There is some instability, and the syringomyelia has reduced. There is a complex anomaly here with various kinds of issues that you can see. This is the syringomalia. This is the, I used to introduce intra-articular spacers, but I don't introduce spacers now. I introduce a lot of bone graft. My thing is that it is not distraction that is necessary. It is stabilization and arthrodesis that is necessary. So no problem here, no problem here. There is no tight posterior fossa. Chiari malformation is secondary to unstable spine. Stabilization is the treatment. This is on the 4th day of surgery. You do fixation, you see the syringomalia reduced. And after about 8 months, this reduced further. And as I have said, it is not the syringe which reduces or not reduced. It is the clinical result. This is preoperative. This is no problem. There is problem here. And syringomalia has reduced. C1, C2 fixation is the treatment. This is another case where the syringe has reduced. This is another case with Chiari. No problem in the atlantodental interval. See the facetal malalignment. And as I have mentioned, whether there is malalignment or not, Chiari and syringe are indicators of unstable spine, and stabilization is the treatment. So this is another case of very complex issue. You do stabilization, learn the art of opening the joint, learn the art of manipulating the facet, and you can create miracles with the patient. This is another case of very bad syringomalia, Chiari malformation. Little bit issue is there. I have done only stabilization, and magic is the clinical outcome. When there is basilar invagination and Chiari, when there is only Chiari, when there is Chiari and syringe, or only syringe and only Chiari, atlantoaxial fixation is the treatment. So even when there is no bone abnormality, like there is no bone abnormality in this case, you have to do C1, C2 fixation. There is no role for decompression. It is a tight fossa, but it is tightness is not the issue. Like here, there is no problem here, little bit problem here. Syringomalia, stabilization, syringe reduced. This is another case of syringomalia, no atlantodental interval disturbance, C1, C2 fixation, syringe reduced in 100% of patients. The other thing is, if your foramen magnum decompression you have done, and if it has failed, which will 100% fail after 2 months, and if it has failed, there is no other treatment. You have to do C1, C2 fixation. Now I am getting many patients from all over the world where foramen magnum decompression surgery has failed, and I have done stabilization. So this is one patient. You see foramen magnum decompression is done. Syringomalia, Chiari, I do fixation, and I create miracles. I create magic. And I give new life to these patients. And there is no doubt or no confusion. Now I have got more than 550 cases of Chiari. 100% patients have been treated by stabilization. No question of decompression. Stabilization is the treatment, and absolute magic is the clinical outcome. This patient was operated 13 times, various kinds of shunts, ventriculoperitoneal shunt, lumboperitoneal shunt, syringe shunt. And then I treat this patient who was a very big engineer in a very big institute in our country, and he is back in his institute. So this patient was treated by shunt and this decompression and various other forms of treatment. And you see there is a big syringe, and the syringe has reduced after C1, C2 fixation. I'm repeating, whether the syringe reduces or not, that is not the issue, but the patient will dramatically recover in his symptom. Whether the patient is old, whether the patient is of pediatric age, whether the patient is infant, presence of Chiari is an indication of unstable spine, an indication of need for stabilization. So this is a small little child where there is syringe and Chiari and speech disturbance, sleep apnea, urinary incontinence, and various other issues. I have got patients who have come with urinary incontinence. I treat C1, C2 fixation, urinary incontinence gone. There I get patients movements disturbance. I treat the C1, C2, eye disturbance reverse. So this is a very, very huge thing in our specialty of spine and neurosurgery. Idiopathic syrinx, when the syrinx is present with Chiari or without Chiari, with basilar or without basilar, no shunt, this is unstable C1, C2, do C1, C2 stabilization, and an absolute fantastic clinical result. So in chronic situation, there can be short neck, short head, short spine, short body neck. All these are indicators of atlantoaxial instability. All these are indicators for the need for stabilization. And all these can reverse in the immediate postoperative period. This kind of short neck, short body. You see, brother is taller, he's short, and not in the immediate vicinity of C1, C2, even spinal kyphoscoliosis. There is Chiari malformation, there is syringomalia, and there is kyphoscoliosis. So this kyphoscoliosis is secondary to short spine. Like short neck will create torticollis, short spine will create this kind of kyphoscoliosis. Do C1, C2 fixation. You see, this is kyphoscoliosis, and this is in the immediate after about 1 month of surgery, it has become straight. In these kind of children, kyphoscoliosis in this age group, my feeling is about 80% of patients are due to central or axial instability. Multi-segmental stabilization is a negative form of treatment. Atlantoaxial stabilization is the treatment, and believe me, there is a magical clinical outcome. When this kyphoscoliosis is present with syrinx or without syrinx, with Chiari or without Chiari, with any cranial malformations or not, there can be central instability. So it is a very huge thing to understand what is central or axial instability. It can itself be a cause of myelopathy. There is no compression, but presence of syrinx is an indicator of atlantoaxial instability. Presence of bifid without any compression, you have to do C1, C2 fixation. So my complete belief is that foramen magnum decompression is a surgery of historical importance, and Chiari malformation should not be called Chiari malformation. It is Chiari formation, and atlantoaxial instability is the cause. So thank you very much, my dear friends. I hope I have given some message, and I hope our patients can improve with a different kind of treatment. Thank you very much.
Thank you, Professor Goel. And I learned a lot from you, and this is several times I learned more and more, although I didn't do the spine surgery. But I know this is a very, I think it's quite a unique treatment for the Cherry's malformation. Maybe sometimes now it's open, and we can invite you to treat this kind for example. And I think your philosophy is quite unique, and but the result is very convincing. Thank you.
Thank you, Zubin. Thank you very much. I have absolutely no doubt as to what I'm saying, because it is now based on many, about 5,600 patients. So it is a very big number now. It is not a small number. And we have beautiful results consistently. So it is here. This concept is here to stay. The only issue is that in Chiari, in syrinx, it is sometimes the atlantoaxial fixation is a difficult surgery. It's not very easy. And foramen magnum decompression is a very easy surgery. So many people will like to just do foramen magnum and run away, but that is not the treatment. C1, C2 stabilization is the treatment. and an absolutely positive result can be expected. Goel.
Yes, thank you.
Okay, Harshad, do you have a question? And then perhaps you can lead the moderation. Harshad?
Hi, Atul, you are always on top of the world when you are talking about Arnold Chiari, C1C2, and craniovertebral junction. And I must admire you and congratulate you for a wonderful talk you have given. And a lot of insight has been given. And we really understand now more and more after your talk that it is always the C1, C2 and instability rather than just doing a decompression. Yes, I agree that it is little difficult operation for many people in view of a lot of venous plexuses. Many times the anatomy is disturbed and the high riding vertebral artery. But you have mastered the technique and you have shown to many of us, and you're training so many neurosurgeons all over the world. And wonderful technique. And we have started doing this since long time after you have shown to the world. It is a C1, C2 instability rather than a foramen magnum decompression. Wonderful. I must congratulate you.
Thank you, Harshad. Thank you. Now here in the audience, I can see Mohammed smiling. Mohammed, what do you have to say?
Yes, dear Professor, I am so happy to hear your unfinished topic last month. Yeah, some words I just want to say to you. I had cadaver dissections to my friends yesterday. I showed my friend the atlanto-occipital joint and the C1, C2 fasces. Although I didn't find any sign of atlanto-axial instability, but still I showed my friend how to do the C1, C2 fixation. And I showed them why we do not have major concern about vertebral artery injury and how to preserve the C2 nerve. Thank you. We all enjoy your beautiful concepts and your beautiful philosophy, your beautiful technicals. I'm looking forward for your next workshop and your next trip in China. Thank you.
Thank you, my dear friend,
Hello.
my dear young friend.
Go ahead, Mohammed.
Yes, Mohammed, what do you have to say?
Nice to see you. Nice to see you, sir. I hope you're
Thank
doing well and all your family.
Thank you.
I want to say only one thing. That once, sir, you said that if you want to do it, you have to know it here. And I'm facing some difficulties explaining it to the other surgeons and the people. But the thing is, now I see that they have to know it in their head, because it's difficult for the other people and the other surgeons, because always the patient, they are going to seeing other surgeons and stuff, and they're saying, nah, this is. But I have done it once, I want to tell you, and it's magic. It was difficult for me, but I did it. So that's the only news that I want to tell you. It's difficult surgery, but all neurosurgery is difficult. Thank you so much. I see that you are adding some new slides and a new new ideas and concepts. So I think I'm a little bit late. I have to come back to Mumbai and to catch up some new concepts.
Yes, you have to
Thank
come
you.
again.
Thank you so much.
Thank
So,
you,
Professor Goel, I have a question. So, some cases it looks very complex case, but you only do the C1, C2 fixation, and how long would you wait for the recovery of the patient, and then what kind of is there any opportunity to do the further some additional treatment for this kind of complex condition, if the patient not very recovered very well?
See, that is the issue. You see, if the patient, I have to tell you that if you read my articles on this subject, I talk of 100% recovery. I have not had one single patient in my entire series where I have reoperated. There are several cases of complex basilar invagination, bone malformations, and you see this issue of central or axial instability is huge. This issue of chronic atlantoaxial instability is huge, and it has got implications in the treatment of Chiari, in the treatment of degenerative spine, in the treatment of OPLL, in the treatment of Hirayama disease, and in several other issues. So my feeling is a revolution, a complete revolution in spine surgery is possible. This concept is absolutely novel and it is futuristic. And I have no hesitation to tell you, Zhu, that this philosophy will eventually take over. Only thing is, because the C1, C2 fixation, people are a little bit hesitant to do because people are not very familiar to do, particularly in complex cases. In complex cases, to open C1, C2 is not easy. But if you can do it, that is the treatment. So I have seen now over the world, I see many people trying this, many people doing this, but I have to, still continue my battle against many questions. People say no, no, here and there, but I have to ultimately succeed because we are not here to satisfy our own ego. We have to treat the patient. Patient has to improve, and ultimately patient is our life. And that is what I am giving the message, that patient will improve dramatically, permanently, if you do a good fixation.
Okay, thank you.
Hey, Takashi, would you like to comment on?
Thank you, Dr. Goel. I'm Dr. Takashi Kon from Tokyo, Japan. Thank you for a very informative lecture. In a case in Japan, also Chiari malformation, sometimes we encounter sometimes not a complete treatment of decompression. SS shunt will be done, and the recurrent and the deterioration we experience. So I learned a lot from now. So I will disperse them to your concept to learn appropriate surgery. Thank you so much.
Thank you, Takashi. Thank you very much. And you know what, Takashi? I am now presenting one series, which will be relayed by John Bennett today.
John Bennett?
In Neurosurgical TV.
Okay.
And this is Revolution in Spine Surgery. I am going to give 20 episodes, 20.
20, okay.
And today, after about 1 hour, I am giving a philosophical lecture on disc. And then I will follow with subsequent lectures over 20 episodes. You see, and you know, Takashi, I was never really a spine surgeon. My whole life I spent in cavernous sinus and complex skull-based surgery. But now, you see, I'm talking about spine. But I want to now give this beautiful message, not just for Chiari, but for degenerative spine. I'm saying about, so this is John has put this, so this series, Revolution in Spine Surgery. So my first episode is Divinity of the Disc, which will begin in about 2 hours time. And then I am going to give lectures on subsequent issues on OPLL, on herniated disc. What is the treatment of herniated disc? Revolution. What is the treatment of lumbar canal stenosis? Complete revolution. So this revolution in spine surgery I am going to introduce. So I wish Takashi and I wish Zubin also, and of course my other friends, young friends, Zandong is here, Mohammed is here, and let us celebrate this. Let us celebrate this revolution in spine. Okay, Takashi?
Okay, thank you.
Very good. Any other comments, questions from anybody? This is Atul Goel Day in the world of neurosurgery. Okay, Wan Lee, how are you doing today?
I'm here. Okay, so thank you, Go. So maybe we can keep according to your talking. Maybe we can arrange more special webinar for you for further discussion. Okay. Thank you again. Now we should move to the second speaker of tonight, Dr. Zhou from Xuanwu Hospital. Right? He will talk about the target therapy for the IDH mutant glioma. So yeah, it's Dr.
Okay, all set?
I'm not sure.
I think,
Where's
Yu Yang, are you there? Are you there, Yu Yang?
Oh yeah, yeah, sorry, yeah, Dr. Yang, yeah. I saw, I can.
Oh, there we go. Okay.
Oh,
Thank you.
oh, sorry, yeah.
Okay,
I made some
Dr.
mistake.
you want to put it on presentation?
Yeah, sorry,
mode?
I made mistake. Should be Dr. Yang from our hospital, Beijing Tiantan Hospital, and he will talk about the biomarker for intracranial aneurysm. Yeah, sorry, yeah, I made mistake for introduction.
Nothing, Professor Zhao. Thank you very much. Good evening, everyone. I'm Yang Yi from Beijing Tiantan Hospital, and I am one of doctors in Professor Wang Suo's team.
Excuse me, can you put it in presentation? There you go. Thank you.
Can you hear me?
Perfect. Yeah, perfect.
I want to share our research about multi-omic markers of intracranial aneurysm instability in Chinese population. Intracranial aneurysm is an outpunching of the artery wall, and it becomes a common cerebral vascular disorder in China. The prevalence of unruptured aneurysm was about 3% all over the world. However, a cross-sectional study in Shanghai showed the prevalence of unruptured aneurysm was 7% in Chinese adults aged 35 to 75 years, though the rupture rate was only 1% per year. The subarachnoid hemorrhage was has high mortality rate, about 22 to 26%. It means we should intervene the aneurysms with high rupture risk, but the complication risk of endothelial therapy was about 5%. For neurosurgical therapy, the risk was about 8%. It's a dilemma of aneurysm treatment. If we choose aggressive intervention, patients may suffer from interoperative rupture, recurrence, ischemic stroke, or infection. For conservative strategy, aneurysm rupture may cause poor prognosis. So physicians are required to balance the risk of aggressive and conservative treatment. The problem is how to evaluate the risk of aneurysm instability. Aneurysm instability represents rupture and growth during follow-up. The growth means the increasing of maximal diameter and new appearance of irregular shape. And for stable aneurysm, physicians may recommend conservative treatments, including comorbidities control and radiological follow-up. Unfortunately, there is no model can predict the long-term risk of aneurysm instability. We think the instability of aneurysm is associated with multi-omic markers, including morphological markers, hemodynamics, vesicle imaging, biology, and comorbidities. And the following slides will focus on these markers. For morphological markers, previous studies established several models such as physics score and in-depth score. This model focused on clinical information and morphological features such as aneurysm size and the shape of aneurysms. However, there were several limitations in these scores. The left graph shows the distribution of physics score finds the score concentrated on 4 to 6, and that could not discriminate the high or low risk of aneurysm rupture. In the right graph, another study found the accuracy of 3 models was not more than 80%. Another limitation exists in previous study was that the prediction model mainly focused on ruptured aneurysm instead of pre-ruptured. In fact, the radiological presentations were different between the two states. The unclear causality impaired the accuracy of morphological models. So, prospective studies are recurrently required. In addition, morphological markers is more than aneurysm size and shape. Size ratio and expected ratio also performed well in aneurysm risk evaluation, such which were often ignored in previous studies. Size ratio and aspect ratio was not included in physics and or in-depth scores. Our team conducted a prospective cohort from 2017. The objective is to predict the aneurysm stability with 1 to 3 years. The cohort is based on 29 medical centers in China. We have recruited the patient and performed a 2-year follow-up. The prediction is planning to evaluating the risk from multi-omic markers. Our research combined morphological and hemodynamic markers. We found the combination of multi-omic markers could improve the model accuracy. For hemodynamic markers, previous studies reported the important role of hemodynamics in aneurysm rupture. Washer stress is the basic index in hemodynamic analysis. It's defined as the friction between the vessel wall and the blood flow. We investigate the hemodynamic markers of ruptured and unruptured aneurysm in Chinese population. In our research, the lower washer stress and the larger washer area were associated with ruptured aneurysm. The biological mechanism of hemodynamics was complex. We prove a pathway of hemodynamic effect. The low shear stress may cause endothelium dysfunction through the FAK and NF-κB signal pathway. Integrin alpha 5 and annexin A2 may be the sensory receptor and induce FAK activation. The dysfunctional endothelial cells release more pro-inflammatory factors in vessel wall. The pro-inflammatory factors degrade the extracellular matrix and recruit the inflammatory cells such as macrophage and monocyte. The inflammation and the ECM degradation make aneurysm rupture. And based on about 1,000 unruptured aneurysms, we establish a radiological stratification model. The final evaluation markers, including size ratio, aspect ratio, hypertension, irregular shape, and bifurcation. The model can distinguish unstable aneurysm from the stable aneurysm. The model was adapted from the decision tree, which is one of machine learning methods. And we further designed a clinical trial for testing the model performance in clinical practice. The junior clinicians give the judgment of stable from the baseline images without and with the help of the DT model. We proved the model could improve the accuracy of instability judgment. For vessel wall imaging, high resolution enhanced MRI is a promising technique for assessing wall structures of unruptured aneurysms. The research was performed in Shanghai. They compared the aneurysm wall enhancement with the interoperative and immunohistochemical representations. The result showed the wall enhanced was associated with inflammation in vessel wall and irregular shape and large size was also significantly related to the wall enhancement. And we followed aneurysm patients with a high resolution vessel wall MRI, as shown in the graph. The partial enhancement was more obvious in the ruptured and growing aneurysm. We recruited about 200 patients and matched the vessel wall images with aneurysm specimens. Wall enhancement index and some morphological features were comparable with the histopathological classifications. Among these, type D was associated with higher wall enhancement, which had an extremely thin wall and high risk of rupture. In our research, limitations still exist, such as lacking natural history in Chinese population and for vessel wall MRI and the hemodynamics index, the preliminary results required further limitation. Biomarkers show the biological mechanism of aneurysm rupture through proteomics, genetics, metabolomics, cytokines, and so on. The consensus on the biomarkers of rupture was inflammation, infiltration, and extracellular matrix degradation. A research in Chinese population constructed a comprehensive proteomics for serum protein. 113 protein markers show the differences between the ruptured and unruptured aneurysm. Machine learning successfully classified aneurysm from healthy controls and unstable aneurysms. Many factors may influence the metabolisms of aneurysm patients, such as SAH, diet, exercise, medications, and other disorders. Biomarkers change with the metabolism, so the effect of biomarkers on aneurysm should be further evaluation. We suggest the biomarkers should be stable, detectable, representative. The stable biomarker were defined as the markers which were co-dysregulate with the stand trend at 2 time points before the outcome event occurred. The detectable markers should change with the stand trend in serum and tissues. The representative biomarkers should have significant differences between rupture and unruptured aneurysms. Besides the marker discovery, we also establish a risk stratification model and performed an in vivo validation of biomarkers. Metabolomics and proteomics analysis were performed on 10 ruptured aneurysm tissues and 10 unruptured aneurysm tissues in the discovering cohort. Untargeted metabolomics analysis identified 38 altered metabolites between ruptured and unruptured aneurysms. Lipids and lipid-like molecules accounted for 26% in altered metabolites, including oleic acid and arachidonic acid. The scatter plots present a good consistency of oleic acid and arachidonic acid between aneurysm tissues and serum. The higher the expression in the tissue, the higher the expression in the serum. The ICH scan proves the increasing expression of interleukin-1 beta and decreasing expression of interleukin-1 receptor antagonist in ruptured aneurysms. The proteomics analysis also presented good consistencies of interleukin-1 between aneurysm tissues and serum. We compared the serum of growing and stable aneurysms at diagnosis and during follow-up. Lipids and lipid-like molecules expressed stably at different time points, and altered metabolites enriched in the biosynthesis of the unsaturated fatty acids. The volcano plots revealed the altered metabolites and cytokines between growing and stable aneurysm at different time points. We find 6 metabolites and 4 cytokines expressed stably and significantly. In conclusion of biomarker discovery, first, we conducted a metabolomics analysis on ruptured and unruptured aneurysm tissues, and we found the 38 altered metabolites. Second, we compared serum metabolites between growing and stable aneurysms at different time points. The metabolites in serum and tissues were also compared to test whether they change with the stand trend, and we found 6 stable metabolites. Finally, 3 altered metabolites performing stable were identified as the biomarkers of aneurysm instability, including oleic acid, arachidonic acid, and alpha-linoleic acid. In the same way, we identified 4 cytokines as biomarkers of instability, including interleukin-1 beta, interleukin-1 RA, MCP-1, tumor necrosis factor alpha. The cytokines were enriched in pro-inflammation and anti-inflammation. Finally, the 3 metabolites and 4 cytokines composed the biomarker bank. Then we established a model to evaluate the rupture risk of unruptured aneurysm using clinical, morphological, and biological markers. The derivation cohort include about 700 patients with single aneurysm for model establishment. The importance of markers was evaluated using mean decrease gene in random forest. The final features were oleic acid, NF-alpha, interleukin-1 beta, arachidonic acid, size ratio, and irregular shape. The RF model had the highest accuracy to identify unstable aneurysm, followed by the SVM and the Cox groups. The accuracy of random forest model reached 93%. The model stratified aneurysm into a high-risk group and a low-risk group. Within the derivation cohort, the patient in the high-risk group had a higher risk of suffering instability compared with the low-risk group. Our instability classifier was superior to the PHYSIS and ELAPSE scores. To validate the performance of instability classifier, the validation was conducted based on the cohort, including about 500 aneurysm patients, and perform a 2-year follow-up. The accuracy of model in classifying unstable and stable aneurysms was 94%. It suggested the great robustness of the model. This research is published in Science Beauty and is carried out by Professor Wang Shuo and his team, cooperating with Tongxin Zhiyi. Our team also explore a deep learning approach to automatic morphological measurement, leading calling design, and multi-omic prediction model of aneurysm instability. The multi-omic markers may develop multi-omic management of unruptured aneurysms. The new therapeutic target of aneurysm appeared with the investigate of biomarker. The management of unruptured aneurysm may turn to medication therapy such as cytokines and techniques for screening aneurysm with a high-risk group. The biomarker target molecular imagery may prove a new approach. And this is the end of my share. Thank you for your attention.
Thank you, Dr. Yang, for your nice talk about the biomarker for aneurysm. So, actually, can you give us a short summary of of your finding? Is there any new biomarker which can predict the aneurysm rupture or the outcome of aneurysm treatment?
Okay. In our research, the lipid and the lipid-like molecules.
Can you move your camera up or down, please? We can't see your head. It's half your head. Yeah, just move the camera. Yeah, please. We want to see your beautiful profile.
You can see my bed.
That's beautiful. Okay, thank you.
Well, we in our research, we can find the lipid and lipid-like molecules express identify the differences between the rupture and unruptured aneurysms, including oleic acid. The oleic acid is expressed higher in the unruptured and in the stable aneurysms, and the arachidonic acid is expressed higher in the unstable aneurysms. The arachidonic acid is associated with the COX-2, and the COX-2 is the target of the aspirin. So it may be the new idea of the aspirin in the clinical treatment.
Okay, Wan Li, any more
This is my
questions?
answer.
Okay, Wan Li, any more questions? Hello, Wan Li, are you there?
Hi, yes, I'm here. So, are there any other questions?
Okay, go ahead. Anybody else have a question or comment before we close? Hello, Ahmad from Afghanistan. How are you? You want to say hello to the international group of Neurosurgery? Are you there, Ahmad? Before we close, I want to give you a chance to say hello from Afghanistan. Well, perhaps not. Okay, Wan Li, thank you very much. And thank you, Yi Lang, and thank you, Dr. Goel. Let me quickly show you in 1 hour, we have the Revolution in Spine Surgery with Dr. Goel to give some of his fans a chance to interact with him. Otherwise, thanks, Benzu, and we'll see you all next week. Thanks for participating. Adios.
Thank you, John. Thank you.
Thank you.
Okay.
Bye-bye, John.
Okay. Bye-bye.
Thank you.
Thanks,
Yuan
Ben.
Li.
Bye.
Okay.
Bye. Okay. Thank you.
Okay.